Assalamu alaikum, everybody. I'm so thankful to the organizers for the invite, and it's been always pleasure being among you all sitting here, because I believe you are the pillars of the medicines, and the core of treatment starts from your level. You are the pillars. And the topic from today for me is the role of ultrasound in female pelvis, and this is it's a huge topic, and it's not possible to cover whole aspects in this short talk, but I'll try to be brief and quick so that we can cover maximum of the things. And by the end of this talk, I'm sure you will be refreshing your knowledge, because I know most of you people are doing these pelvic scans, especially our honorable female doctors. They are doing these scans at their clinics, and of course the male doctors also. So this in ultrasound, the major part of a routine scanning is the pelvic ultrasound. Either it's the trans-abdominal or it's the transvaginal ultrasound. So let's kick off with the first slide. A little bit of introduction to the female ultrasound. As we know, it's a non-invasive diagnostic imaging test that uses sound waves to image female pelvis, and to the pelvic organs, which consist of uterus and ovaries, and adnexy. Other than that, we have the unibladder, and it's not only cover this gynecological aspect in this ultrasound. We see the early pregnancy, and whether it's inside the uterus or outside the uterus. So major part of my talk is gynae related, because if we go to the obstetric issues, that will be too long to cover here. The conditions evaluated are huge. There is a huge list of things we see in the small pelvis, starting from the ovarian cyst, polycystic ovaries disease, fibroids, hyperplasias, retained products of conception, endometritis, adenomyosis, polyps, AVMs, hydrosalpinx, biosalpinx in pelvic inflammatory disease. Torsion, very important, because once there is ovarian torsion, it can wake the patient in the midnight, and it's emergency, and it's prudent for a radiologist, for a gynecologist to diagnose a torsion with the help of the clinical background and the history and the ultrasound finding, many structural anomalies. We pick the tracking of follicles we do in a routine ultrasounds, early detection of pregnancy, either it's in the uterus or outside the uterus, less than the ectopic pregnancy. And the most important is the role of intervention, how much we can help you guys, the gynecologist, the physician, by doing different type of interventional procedure in this pelvic area. The examination normally involves two components. We know there is a trans-abdominal ultrasound, which is the initial examination, and almost everybody sitting here does the trans-abdominal ultrasound, and then is the transvaginal ultrasound, which is have edge over trans-abdominal ultrasound, because it's very close to the organs in the pelvic area and give the much more clarity. So again, covering the many aspects in the pelvic area. Equipment, we are all familiar with the equipment we use. We use the convex probe, which has 2 to 5 megahertz range, and the other probe we use is the transvaginal ultrasound. This is how it looks like. It's a very familiar probe. This is how we use the trans-abdominal ultrasound. We put a probe on the anterior abdominal wall, and for this we need to have full bladder so that we make a window through the filled bladder to see the organs lying behind the urinary bladder, the uterus, ovaries, and the adnexy. And similarly, the transvaginal ultrasound is introduced to the vagina, but we don't need to fill the bladder. So that's, we don't need to prepare the patient for the transvaginal ultrasound. But obviously, we need to follow the protocol. We need to have a staff nurse around us, especially when the male doctor is doing. We should have the proper privacy. And above all, we need to take consent from the patient. So before starting the transvaginal ultrasound, whether the patient is agree or not. This is how the normal anatomical structures are seen on transabdominal ultrasound. We know the uterus is hypoechoic in appearance. It's oblong, roughly measuring in a younger female is about 7 into 2.5 into 3.5 centimeter, which turn out to be the weighing. It weighs about 30 to 40 grams. And we have the fundus, the body, and the cervical area, and the central endometrium. The endometrium varies with the phase of the menstrual cycle. Soon after menses, it's thin. In the mid-cycle, it's about 10 to 12 millimeter thin 3-line. And in the premenopausal time, it's a thick 3-line because it has to shed off. This is hypoechoic on transabdominal ultrasound. And these are the ovaries with the scattered follicles. The left ovary, the right ovary. This is how we see in our population, in this region, South Asian region, the normal volume of an ovary is roughly about 6 to 9 ml, whereas it's different. The Africans, it goes up to 10 to 12 ml. So anything which is above 10 to 12 ml is considered to be of larger volume. This is what we see. That was on transabdominal ultrasound. This is what we see on the transvaginal. This is very close look, very much clarity, or the serosal surface is seen with the central endometrium, thick diffuse. This is the pre-menstrual phase, and this is the cervix, and we see the ovaries very clearly with the follicles. So, how to proceed in different complaints of the patients. So investigation of a pelvic mass, we start with this pelvic mass. These could be coming from the uterus or coming from the ovary. The most common pathology we find or a mass in a female is a fibroid in the uterus, where this can be found incidentally. These can be symptomatic depending on the size and location. And these can be of different location. This could be a submucosal, it could be intramural, subserosal, even it can be seen in the broad ligament. The other pathology which may mimic a mass is adenomyosis, and sometimes rarely there can be sarcomas in the uterus. Other masses other than uterus are the ovarian masses, which comprises of a simple cyst. I'll just talk about simple cyst, hemorrhagic cyst, mature cystic teratoma, other cysts like endometriomas. So we start with the fibroids, the most commonly seen. The fibroids are the leiomyomas, are benign tumor of myometrial region, and the most common solid tumors. Incidentally seen, and fibroids are responsive to the hormones. They are stimulated by estrogen, being rare in puberty, and they commonly accelerate growth during pregnancy. So this is very important slide, the different location of fibroids and its implications. We can see a myometrial fibroid. This is the intramural, and this one is a subserosal. Just in the subserosal region, this is the pedunculated. This is again a subserosal. It may compress the urinary bladder. Patient may present with the dysuria or frequency of urination. And this is subserosal, again the large one compressing the rectum. Patient may present with a frequent history of the constipation. So these are the different implications. The submucosal fibroid may hamper in the patient to get pregnant. So this is very, very important. When we start doing scan, we should know the exact location of the fibroid and its size, because it has different implications. The uncomplicated complicated leiomyomas are usually hypoechoic, as talked about. They can be calcified. They may undergo cystic degeneration. Sometimes the cystic degeneration is painful. Patient may present with the pain with the mass in the pelvic area. This is one of the picture of ultrasound. This is transabdominal ultrasound, hypoechoic myometrium, endometrium, and this is the fibroid in interior wall extending into the subserosal region. These are usually rounded, and they have a pseudocapsule, and pseudocapsule contains a neurovascular bundle. When we turn on the Doppler, we might see scanty flow in the parenchyma of the fibroid. This is another example. This is a subserosal pedunculated fibroid. This is lying outside the fundus of this uterus. This was very recent, last night, on the 9th of February. I just scanned. There was a fibroid with the calcific rim. This is again a subserosal fibroid hanging out of the uterus. So this is the subserosal calcified fibroid. Submucosal, I talked about. They can hamper, they can hinder the pregnancy because it is distorting the endometrium. And another way to diagnose precisely the submucosal fibroid, we can infuse the fluid in the endometrial canal, and we can see the interface between the fluid and the myometrium. So these were the few examples of the fibroid. So talking about ovarian cyst, another common pathology seen, there is a pattern recognition of the ultrasound, often follow fairly confident diagnosis. Starting from, if you go the anti-clockwise, this is the simple cyst which has thin wall, smooth. I'll show you some examples. No internal echoes. Hemorrhagic cyst, relatively thick wall with internal echoes. Endometriomas have its own peculiar appearance, and mature cystic teratoma among the ovarian cysts. This is about the 50% of the cases we are able to see the mature cystic teratoma, and last but not the least, the malignant cysts have its own features. We'll see one by one. Simple cyst, these are purely anechoic and lesion with thin walls. Usually they are unilocular. We don't see a solid component. We don't see any flow. This is one of the examples. Simple cyst. This is about 5.3 into 5.5 centimeter. Very smooth, gentle wall. No internal echoes. No septi. No solid component. When we turn on the color Doppler, we don't see any flow. Hemorrhagic cyst, when a Graafian follicle or follicular cyst bleeds, a complex hemorrhagic ovarian cyst is formed. Ultrasound findings allow a confident diagnosis because it has a cystic mass which contains solid appearing area with through transmission without internal flow on the Doppler, and typically with convex margin, because this turned out to be a blood clot in a hemorrhagic cyst. So please don't confuse this with a solid component. This is one of the example. This is a very typical appearance of hemorrhagic cyst. Walls are relatively thick. There are internal echoes. We can see the fibrin, the lace-like pattern inside. This is the fibrin, and this is a very classical look of a hemorrhagic cyst. That was anechoic simple cyst. This is hemorrhagic cyst, and with the passage of time, when the clot retracts, it gives a solid appearance. So how to differentiate? Either it's a solid component with flow. Just turn on the Doppler, you don't find a flow. So this is a resolving cyst, starting with the formation of a clot. Similarly, again, a cyst, with the time it has clotted down, it has a convex margin, it has an interface with the clear fluid in the same cyst. We turn on the Doppler, we don't see any flow. This is a hemorrhagic cyst with a clot formation. Endometriosis, another very, very prevalent pathology in our society nowadays, especially in the young females. We come across daily unfortunate patients with a history of endometriosis, and as we know, it is classically defined as presence of functional endometrial glands and stroma outside the uterine cavity. The most common locations are endometriotic deposits are ovaries, then in the pelvis and peritoneum. These are the sites where the red glows shows the sites where the endometrial tissue is implanted. These are ovaries, this is the peritoneum, it can be on the GI tract, and even it's higher up in the abdomen, it seems. So endometriotic cysts have a peculiar appearance. It has homogeneous and hypoechoic mass appearance, low-level echoes, no internal flow on Doppler, no enhancing nodule. Usually in 30% of cases, echogenic foci are seen in the wall. This is very important. Sometimes you see low-level echoes and echogenic foci, and these echogenic foci are the degradation of the blood cells, and which leads into the fatty deposit. This is very classical of the endometriotic cyst. It has a debrinous low-level echoes. It has relatively thick wall. This is due to undergone the fibrotic reaction over period of time. It's not gentle as it was in a unilocular thin-walled cyst. So this is a classical example of endometriotic cyst. When we turn on the Doppler, we don't see the flow, but of course this is correlated with the clinical history. Patient present with the history of menstrual pain preceding the menses. Patient experience the pain, and of course in a married woman, they mostly present with infertility. This is another example, the bilateral endometriotic cyst. You see the low-level echoes, and both these ovaries are approximated posterior to the uterus. These are called the kissing ovaries. This is a definite, almost definite sign of endometriosis when both the ovaries become approximate to each other, and this is almost definite sign of the endometriosis. We do sometimes perform the dynamic pelvic ultrasound, and what a dynamic pelvic ultrasound, we push the probe. Normally in the normal healthy female, the uterus is a little mobile, ovaries are a little mobile. When we push, give a gentle push with the probe, they move from their place, the uterus and ovaries. But once this fibrotic reaction has taken place due to the long-standing inflammation of endometriosis, we are unable to mobilize either uterus or ovaries. That gives what the gynecologists say the frozen pelvis, and we can demonstrate on ultrasound with a transvaginal probe. Ovarian dermoid, as just touched earlier, this is the almost 50% of the cases of the cystic lesions are the ovarian dermoid. They usually are hypoechoic with hyperechoic nodules, and mostly 90% of cases unilocular. They may contain calcification in 30% of the cases, and they may contain hyperechoic linear cause, floating hairs, and fat fluid levels at times. This is a very classical example. This looked like a gut loop, but it was a large dermoid cyst with hypoechoic and hyperechoic component. The volume of this dermoid cyst was about 770 cc, almost reaching to a liter. It was huge, coming from the pelvis going up to the supraumbilical region. This was a big dermoid. Another example, this is called the tip of iceberg sign. We can see only the tip of hyperechogenic nodule in the dermoid cyst. This is another pathognomonic for the dermoid cyst. So what to do with the when you diagnose a dermoid cyst? This is also called the mature cystic teratoma. If the dermoid is less than 7 centimeter, we can follow it up from 6 to 12 months with ultrasound. But once it exceeds this 7 centimeter size, the surgery is indicated because it can torse, it can undergo a torsion, it can rupture. This is a mature cystic teratoma with a Rokitansky nodule. This is just a comparison, cyst with low level echoes. The initial is the endometrioma. I talked about their foci in the wall of endometrioma. These are the fat globules. These are the fibrins in the low level echoes of hemorrhage. And this is teratoma with an echogenic component. So we can confidently differentiate between endometrioma with a hemorrhagic cyst and a dermoid cyst on ultrasound. Few words about a sinister or a malignant cyst. Till now we talked about the benign cyst. When the cysts have the multiple septation which are thick enough, the cutoff value is 3 millimeter. If they are more than 3 millimeter thick, the bell should ring in your head. This is not a simple cyst. It may have a focal wall thickening and it may have a solid component. So surgical resection by oncologist, gynecologist who may request the prior imaging. So when you see these features, we should go for the further imaging for the lab investigations like CA125, clinical correlation, and the further imaging like MRI with contrast or CT with contrast, and of course after that the surgical intervention is indicated. Again, a malignant cyst, the septi are thick more than 3 millimeter. It may have a papillary projection, and on Doppler there is a flow. It may have a frank solid component, and again a flow is seen in this a solid component. The more the solid component and the more the flow, there is a more probability of a malignant nature of the cyst. Polycystic ovarian disease, much prevalent in our society nowadays. Again, young girls present with the symptoms of polycystic ovarian disease. So it generally requires two of the following three criteria: ovulatory dysfunction, clinical and biochemical hyperandrogenism, and polycystic ovarian morphology on ultrasound. So it's a triad. On the one side, there are clinical presentation of a female. How does she present? Suspecting a PCODs. Number two, what you see on ultrasound. Is it a classical picture of peripherally arranged atretic follicles? And number three, in the triad, the third part is the hormonal assay. Sometimes it's a very classical picture. The volume is larger of the ovary, and that leads you to the diagnosis. There are areas, there are cases on the gray zone. Then you have to complete the triad of clinical presentation, ultrasound finding, and hormones comparison. The new criteria to diagnose is the large ovaries more than 10 cc and above, and increase the number of follicles, that is at least 12 and between 2 to 8 millimeter, and mostly at peripherally arranged. This is a classical example. These are large volume ovaries and peripherally arranged follicles. These are almost of similar size, and these are less than 1 centimeter, and central echogenic stroma. A few cases, again, if you see that this is left ovary larger in volume, this is about 16 cc, and the right ovary is about 17 cc. So this is a very classical lace-like pattern at the periphery of the ovary with central echogenic stroma. This is a case of the polycystic ovary. Other areas where we can help to diagnose in the pelvic ultrasound is a retained product of conception. Again, commonly presenting people after delivery, after DNC, they might be bleeding continuously, and they appear to having the echogenic shapeless echoes in the endometrial canal, and they don't find any reason for bleeding. But one feature which can help you diagnose is, yes, you are sure on the basis of history, these are shapeless echoes, widening of endometrial class, these are the RPCs, but when you turn on the Doppler, there is a flow. So that strengthen your diagnosis and confidence that these are the RPCs. Sometime post-intervention, surgical intervention, diagnostic procedure, patient may end up with fever, passing the thick fluid, and there is a suspicion of endometritis. So when we turn on the Doppler, again there is flow with the central fluid in the endometrial canal. A little challenging diagnosis is adenomyosis. Again, just like endometriosis, there is the implantation of the endometrial tissue in the myometrium of the uterus. The uterus grows bigger as compared to the normal. You lost the interface between endometrium and myometrium, and these are the glands. They may sometimes appear hyperechoic on ultrasound. This is a case of adenomyosis, and these patients mostly present with, again, infertility, and or maybe after having kids, they may end up with adenomyosis in some of the cases. This is how it is present. Endometrial polyp, again, on a gray scale, we are confident that there is echogenic structure inside the endometrium, but we are not sure whether it's an endometrial polyp or something. The rule of game is ask the patient to come back again to you soon after menses. When it persists, turn out the Doppler. If there is it has a stalk, and most of the time you find a flow, single artery applied to them. Again, this will be help to diagnose the polyp, because these polyps have implication. They have a role in fertility or intermenstrual bleeding. So when you are confident with your diagnosis, then you can manage accordingly. See, endometrial carcinoma. This is a exuberant case, markedly thickened in a 70-year-old female. The endometrium, which presented with the bleeding, on Doppler there was flow, and it has invaded into the myometrium. This proved to be endometrial carcinoma on biopsy. Sometime there is a bleeding, not understanding why the patient is bleeding, no exact cause clinically, but when we do ultrasound, we find multiple cystic areas because patient had undergone the certain kind of intervention, and when we turn on the Doppler, this found to be the arterial and venous flow. This is the AVM, the arteriovenous malformation. The treatment, we can embolize the vessel, or patient may end up in the hysterectomy. A few words about the ovarian torsion and the pelvic inflammatory disease. At times we are able to see the cyst in the ovary. This is the right ovary. We know this is a simple unilocular cyst, no internal echoes, but on the left side there is a tortuous dilated structure, which is not a ovarian cyst. This is a hydrosalpinx. And when the fallopian tube, the tortuous dilated with incomplete septa, is filled with the thick debris, this is likely the case of the pyosalpinx. Patient may present with a discharge, with a fever, and this is a hugely dilated fallopian tube with the pus or pyogenic material. Similarly, again, the patient presenting with the pelvic pain, with a discharge and fever. When we scanned the patient, this was a tubo-ovarian mass, which was of infective origin. Torsion, very, very important to know about this. A few words about torsion. As we know, this is ovary. They have certain ligaments and the blood supply to it. When it torses to its axis, these vessels, the arteries and veins are squashed between the ligaments, so the blood supply is hampered and the ovary goes bigger in the case of torsion. It can occur a woman in the reproductive age, and a patient may be afebrile, and it may present with the sudden pain any time of the day, and mostly they wake up the patient in the midnight. So on a gray scale, we should know the features of torsion. Ovary is usually enlarged, heterogeneous, and it may have edema or infarction, may be quite amorphous. And very important point, when the ovary is torsed, it's not seen at its normal location. It jumps from the normal location to the midline most of the time, or anterior to the uterus or posterior to uterus. This is a very important feature. Enlarged ovary with change of its position. Check for the underlying mass. There might be associated mass with it, and asymmetrical thickening of the cyst wall. You might see the free fluid along with it. When we turn on the Doppler, as the vessels are twisted, we maybe see the whirlpool sign. I'll just show you. Very important. Length of time and degree of torsion is important. How much time it has taken to give the symptoms, and how much time it has taken to diagnose, because you can salvage the ovary with the passage of time. We know ovary has double blood supply. This is a whirlpool sign. We normally don't see around ovary this such whirlpool vessels. A few cases of torsion. If you see, this is the normal ovary on the right side. Normal measurement 3.6, 2.9 centimeter. But we go on this side. This ovary is of 6.8 centimeter into 3 centimeter. This is the big ovary. This is the normal ovary. This is a big ovary with a cyst, because associated there is a mass. When we turn on the Doppler, we don't find flow. There is no flow in the ovarian parenchyma. This is big. It has gone into cul-de-sac and is a big no flow. This is a classical case of the ovarian torsion. It has undergone necrosis. When I got the feedback after surgery, it was totally necrosed ovary. Another example, the big ovary on the right side. This is left ovary is normal, right side the bigger one. Again, there are areas of hypoechogenicity. Again, the feedback was about this ovary was totally necrosed ovary. A few words, a few last slides. Structural anomalies, we come across so many structural anomalies, so we got to be very vigilant to diagnose, because patient may present with a repeated history of missed abortions. So it's imperative to know the normal anatomy and to diagnose the structural anomalies of the uterus. This can be done with transabdominal ultrasound as well as with the transvaginal ultrasound. The uterus can be the arcuate. There is arc-like structure over here. It can be septate. The septa can be incomplete or complete septa, dividing the endometrial canal into two parts. And similarly, it can be bicarbonate. It has two horns, and the diadelphys, the division is all together from the uterine body up to the vaginal level, and it can be unicornuate. So it's very important to know the normal anatomy and the structural and anatomical features of a uterus. A few examples, the septate uterus, the bicarbonated uterus, and diadelphys uterus. A few words, these were all examples of gynecological application of the ultrasound. A few words about the OPS ultrasound. We can diagnose very early pregnancy, like even starting from the 4 weeks, by transvaginal ultrasound, by 5 or 6 weeks, very confidently with the transabdominal ultrasound. Early, the fetus can be seen. We can see the cardiac activity, the nasal bone, and we can do the dating scan in the pelvic scan. A few words, ectopic pregnancy, when the pregnancy is outside the uterus. These are the number of areas where the ectopic pregnancy can be harbor. The most common is the fallopian tube. It can be in the isthmus. It can be in the ampulla. It can be at the fimbrial end. About the 90% of cases, it's in the fallopian tube. It can be less than 2% in the ovary, and even in the interstitium of the uterus, and sometime in the cervical canal. This is adnexal ectopic pregnancy. We see the blood clot around it, and this is a cervical pregnancy. This is how it's been taken out after the surgical intervention. A few words, a few last slides is regarding the intervention in the pelvic area. This was a case of a solid mass in the right ovary, and it was seen on the transabdominal ultrasound. The gynecologist asked me to do the biopsy, which was not approachable. I did the transvaginal ultrasound. The exuberant flow was seen in this mass, and did the biopsy. This is the biopsy needle. This is probe, and this is the biopsy needle going into the mass, and the biopsy was taken from this mass. Similarly, this is a huge collection in the pelvic area, which was not approachable from the transabdominal ultrasound. Did the transvaginal biopsy. This is the needle again. This is the needle. Look at the time, 11:35 p.m. I started the procedure, and 11:36, in 1 minute time, whole of the abscess was drained. It was like 450 cc of pus which was drained. That all was clear in the pelvic region. Thank you very much.
Thank you very much, Professor Dr. Khalid Rehman Yousaf, for sharing your clinical experiences with us. Now proceeding to the last lecture of today's session, I would like to call upon consultant radiologist